Adela. The greatest glory in living lies not in never falling, but in rising every time we fall. I extend my warm welcome to all the dignitary guests and delegates present here for the Dr. Sudhir Raj N. Memorial Free Webinar Series organized by DIKSHA Academy. Today's session, we will be discussing about Ayurvedic perspective of low AMH, a case study by Dr. Varsha Gaikwad Anand. Before starting the session, I would like to go through a few of the basic instructions to be followed throughout the session. For uninterrupted class session, use laptop with high-speed internet connection. Please make sure your microphone is on mute to have a disturbance-free session. In case of any disruption, please check your internet connection first. And if the problem is within our network connection, kindly raise the issue in the chat box. Filling your full name to be displayed is appreciated. Any questions can be raised, posted in the chat box. Questions raised will be cleared at the end of the session. It's a great pleasure for me to introduce our guest speaker, Dr. Varsha Gaikwad Anand. Dr. Varsha is a renowned gynecologist whose mission is healing through Ayurveda. Doctor graduated from Ayurveda Mahavidyalaya, Sion, and completed her MS in Sri Roga and Prasuti Tantra from Tilak Ayurveda Mahavidyalaya, Pune. She is also a PhD scholar in PTSR, School of Ayurveda, D.Y. Patel deemed to be University. Her current designation is Associate Professor, D.Y. Patel deemed to be University School of Ayurveda. She has presented papers in various national and international conferences. She has worked with Government of India as District Ayush Officer under NRHM project. She was the recipient of Award of Excellence for Best Paper Presentation in Ayur Kaushalya 2017. Her papers are published in peer-reviewed journals like IAMJ, Ayurlog, National Journal of Research in Ayurveda Science, and IJRAR. She has excellence in treatment of infertility, PCOD, ANC care, PNC care, menstrual abnormalities and semen abnormalities, benign breast disease, and breast augmentation. We are extremely privileged to have you in our platform, ma'am. Now, without any further ado, we will turn the time over to respected Dr. Ma'am to enlighten our minds with her knowledge.
Thank you for that wonderful introduction, Dr. Jinsi.
Thank you, ma'am.
Am I audible?
Yes, ma'am. Little bit louder, ma'am.
Let me try this way.
The voice is feeble, ma'am.
Am I audible now?
Yes, ma'am. It's clear now, ma'am.
Okay. This one is better, or the earlier one was better?
This is better, ma'am.
Okay.
Okay.
Just give me a minute to share my screen.
Yes, ma'am, for sure, ma'am.
My screen is visible?
Not yet, ma'am.
Is it visible now?
Yes, ma'am.
The first slide is visible, right? The title.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, thank you so much. Hello, everyone. Myself, Dr. Varsha Gaikwad Anand, as nicely introduced by Dr. Jinsi, that I'm an associate professor in the Department of Sri Roga and Prasuti Tantra, D.Y. Patil School of Ayurveda, Nehru. So here we'll start with my presentation. Yeah. So why I chose this particular topic, that is low AMH, Stands for anti-Mullerian hormone. What is AMH? What is the significance of it, and why it is tested in patients willing for a child? That we'll see in our subsequent slides. First, let's see about the present scenario. Why we are coming up across these frequent cases of low AMH? It is because of the delayed childbearing, voluntarily or involuntarily, is nowadays very common in couples visiting the fertility clinics. And as a gynecologist, whenever a couple with infertility approaches us, the first basic investigations that are carried out, and amongst that, we perform the ovarian reserve test. Now, what is ovarian reserve test? There are various types of ovarian reserve test, and AMH is one of it. When the couple is unable to conceive by normal method or by initial or the basic process, then the couple opts for in vitro fertilization, that is test tube baby. And this AMH level gives a clear-cut indication about the what will be the success rate of that particular in vitro fertilization or IVF. Diminishing ovarian reserve is a phenomenon noted in women during mid or late 30s and at times earlier, reflecting the declining follicular pool and oocyte quality. That means that if you come across any patient who is having low AMH, it directly means that there is a decline in the follicular pool. Now, what is follicular pool? Follicular pool is nothing but like a girl child is born with certain amount of follicles in the ovary. And as the age advances, the follicular pool or the number of follicles in the ovary, they go on decreasing. So the low AMH directly interprets that the follicular pool is declining. Now coming to the ovarian reserve test, ORT stands for the ovarian reserve test. Now what do you mean by ovarian reserve? Say, I will give an example. When you have, say you have certain amount of money and you will keep that in bank. So that amount of money is your reserve. Same way, the amount of follicles or the amount of primary oocytes that are present in ovary is called as ovarian reserve. In majority of patients, it is adequate, but the couples who suffer from infertility, in that case, ovarian reserve is depleted. And to know whether it is adequate or not, we perform the ovarian reserve test. There are various types of ovarian reserve tests like biological, biochemical, biophysical, and histological, as you can see on the screen. Biological includes chronological age, is nothing but the biological age of the female patient. Biochemical includes two types, static and dynamic. Static test includes the topic of discussion, that is AMH. There are various others also like FSH, ratio of FSH to LH, or inhibin B. Dynamic test includes CCCT, that is clomiphene citrate challenge test, and GAST, that is GnRH agonist challenge test. Biophysical includes USG. USG is nothing but we will ask that patient to get her sonography done, and then we will count the AFC, that is antral follicle count, and the ovarian volume. This will give us a clear-cut idea that how much follicles are remaining inside the ovary and what are the chances of that patient to get pregnant. Histological ORT includes ovarian biopsy. It is nothing but you take a piece of ovary outside and you do its histological examination, and you come to know whether there is any functional tissue left for eggs to be produced, or the ovaries has degenerated, or there is a premature ovarian failure. This thing you can come to know by ovarian biopsy. Coming to the very first point that we spoke about, that is chronological age or the biological age. It is long established that ovarian reserve reduces progressively with age. That means as the patient will go on aging, her ovarian reserve will go on depleting. That is, age is inversely proportional to the ovarian reserve. Fecundity in both natural and stimulated ovarian cycles declines with the maternal age. Now, what is fecundity? What is difference between fecundity and fertility? Fertility is patient's ability or patient's patient's ability to conceive, and fecundity is patient's ability to conceive in single intercourse. That is the only difference between fecundity and fertility. So fecundity in both natural means a patient who achieves conception through natural coitus, and stimulated ovarian cycles means we give certain ovulation induction drugs like comulfin citrate is there, letrozole is there, and in both these cases the fecundity is declined with the increased maternal age. It begins to decline in late 20s and becoming more abrupt in late 30s. This decline has been observed in population-based studies and in women undergoing ovulation induction or IVF. Even though fertility does not decline uniformly in women, age is known to be the most important factor determining the pregnancy potential in regularly cycling women. That this sentence only means that if you take two patients, say patient A and patient B, both of 30 years of age, it does not mean that because we are emphasizing on age factor, both of them will have equal amount of AMH or both of them will have equal potential to reproduce. That's why it only means that the fecundity will reduce as the age increases, but it is not uniform. A patient, this can be validated from Ayurveda point of view, that Rutukal is said to be last for say Dwadash Ratra. Okay, if you see the duration of Rutukal as per Ayurveda, it is Dwadash Ratra, but still they have given that a patient or a person who is consuming Ghruta or Kshira on regular basis, in that particular lady, the Rutukal will last for entire month. So the point I'm trying to emphasize over here is that though I am saying that the fertility or fecundity will reduce as the age increases, it is not uniform. That means if you take two patients of same biological age, that does not mean the both of them will have equal potential to reproduce. Both of them will have different potential to reproduce. Okay, coming to the next slide. So here is a diagrammatic representation of how fertility reduces with increased maternal age. So here is the number of y-axis is indicating the number of follicles, and this x-axis is indicating the age of the patient. As you can clearly see, this solid line is indicating the reducing fertility as the patient's age is increasing. You can see that the end of fertility is between 40 to 50, and declining fertility is observed between 30 to 40. So if a patient is in age group of 30 to 40, you can say her fertility is declining, and between the age of 40 to 50, it is the end of fertility, and 50 to 60, no need to say, it is the age of menopause. Am I clearly audible?
Yes, ma'am, you're audible, ma'am.
Yeah. Coming to the next slide, that is biochemical markers of ovarian reserve. We have already seen the classification of ovarian reserve tests. Now I will be explaining the few commonly performed ovarian reserve tests. One of them is follicle stimulating hormone. Now FSH is produced by pituitary, and it is usually measured on day 3 of the menstrual cycle. So whenever a patient with infertility approaches us, there are few basic investigations that we carry out, and FSH is one of it. An increased FSH in level indicates follicle depletion. That means if you are getting FSH level very high, we can say 0 to 15 is a baseline. FSH should be somewhere between 0 to 15, and if it is too high than this 15 threshold, then it indicates that there is a follicle depletion. Now why this occurs, I am telling you. Like FSH, I just now said that FSH is produced by pituitary. What is the function of FSH? Function of FSH is to stimulate the production of follicles in the ovary. I hope all of you are aware with HPO axis, that is hypothalamus, pituitary and ovarian axis. So under the influence of pituitary, FSH will stimulate the ovary to secrete or to develop the follicles for the ovulation. Now, if there is some pathologies lying at the ovarian level, okay, so if there is premature ovarian failure, let's say for example, then what will happen? The pituitary will produce more and more amount of FSH in order to stimulate the ovary to produce the to stimulate this follicles to develop. So if there is a very high level of FSH, don't be very happy that the follicles are getting stimulated. No, it is the opposite of that. If FSH is too high, it indicates the premature ovarian failure. Now, FSH, you cannot measure on any day which you want. FSH has to be measured on day 2 or at max day 3 of the cycle, because FSH does show cyclical variation. What do I mean by cyclical variation? That if you say measure FSH on day 3, and if you measure FSH on day, say, 16th of a cycle, there will be cyclical variation and the readings or the value will not be same. And the standard day of measuring FSH is either day 2 or day 3. Okay, now coming to the main component of our today's topic, that is AMH, that is anti-Mullerian hormone. Now, what is AMH? It is a dimeric glycoprotein exclusively produced by granulosa cells of preantral and small antral follicles in the ovary. So if I ask you where AMH is produced, your answer should be the AMH is produced in ovaries. Who produces it? Preantral and antral follicles. The production of AMH starts from the follicular transition from the primordial to primary stage, and it continues until the follicles reach the antral stage with diameters of 2 to 6 mm. That means follicles who are in resting phase, they will not produce the AMH. The follicles who are in antral stage, and what do I mean by antral stage? The follicles which have attained the diameter of 2 to 6 mm, only those follicles will produce the AMH. With decrease in the number of AFs with age, AMH production appears to diminish and becomes undetectable at and after menopause. So it is very much obvious if antral follicles are secreting AMH, and if antral follicles themselves are getting depleted, AMH will get depleted. So AMH levels strongly correlate with the basal antral follicle count, AFC, that we say, and it is measured by the transvaginal sonography. Unlike other biochemical markers, it can be measured on any day of the cycle and does not exhibit intracycle variability. So this is the difference between the previous slide that we have seen, FSH and AMH. Like FSH has to be measured on day 2 or day 3, but AMH can be measured at any point of the cycle because it does not exhibit intercycle variability. Now coming to what is AMH in a nutshell, like if I have to talk about AMH, I will go on talking about AMH for next 1.5 hours. But in short, if I have to tell you what is AMH, it is a hormone produced by cells in the follicles that contain an egg in woman's ovary. AMH indicates the number of eggs being produced during a woman's monthly cycle. The level of AMH in woman's blood is good indicator of her ovarian reserve and is helpful in assessing her fertility status. That means AMH level, your AMH level directly tells about how many functional follicles are remaining in your ovary, and hence if your AMH is low, it directly means that there is no functional ovary, follicles are left in the woman's ovary. Decreased AMH level are seen in those who respond poorly to fertility drugs. So if I see if any patient's AMH level is low, I know in my mind that this patient is going to respond poorly to all the fertility treatment that I am to give her. One advantage of AMH test is that it does not change over the course of menstrual cycle, and it can be tested at any time of the month, which we have seen in the previous slide. Now coming to, like I have been saying that functional ovarian reserve, but what exactly is this ovarian reserve? Now, to understand this concept of ovarian reserve, let's go back to the oogenesis. Oogenesis is nothing but a process of formation of female gamete. Okay. Oogonia is nothing but the earliest form of follicles. Okay. So at 20th week intrauterine, that means if a patient is pregnant and if she is having a female child in her womb, at 20th week of pregnancy, that female child, okay, don't get confused, not the mother, the female child at 20th weeks of pregnancy will have around 7 million follicles in her ovary. Okay, over a period of time at birth, the primary oocytes will deplete to, from 7 million, it will deplete to, from 7 million, it will, from 7 million, it will deplete to somewhere around 2 million. At puberty, this around 4 lakh primary oocytes will be present. And during the reproductive lifespan of a woman, around 400 primary oocytes ovulate every month. So if you ask me how many oocytes rupture during entire reproductive lifespan of a female, then the answer will be around 400 oocytes ovulate during reproductive lifespan. So when I'm saying about ovarian reserve, I mean these 400 primary oocytes which are present in woman's ovary after puberty. Now coming to AMH, by this time you must be knowing that what is AMH. It directly tells you the amount of functional follicles left, and it directly correlates with the fertility of that particular patient. Now coming to what will increase and what will decrease this AMH. Now for factors which will decrease this AMH includes increasing age. We have seen already, as the woman's age will increase, the AMH level will go on decreasing. Race and ethnicity. This also I have clarified that as per Ayurveda, the Rutukal will last normally will for Dwadash Ratra, that is 12 days. But if a patient is having good amount of Gruta or Kshira that we can correlate with good fat, then her AMH level will be good, and anything opposite to this will decrease the AMH level. Obesity, we all know that majority of fertility problems can be taken care if the patient reduces few kgs or few inches of her body. Smoking and alcohol intake, again known to cause a decrease in AMH. Administration of gonadotrophins, administration of chemotherapy or radiation. So if a patient is having any sort of cancer and she is being treated with chemo or radio, keep that this in mind that her AMH level will be low. Surgical removal of one or both ovaries and contraceptive pills. This will reduce the AMH level. Now coming to blood level of AMH. Now we have been talking about AMH. If it is low, the patient will have difficulty in conceiving. But what is the optimum level of AMH, which is considered high, which is considered low? Let's have a look at it. So PCOD patients usually have high AMH, but don't be very happy with it, because high AMH does not indicate good fertility. For good fertility, we should have optimum AMH. What is optimum AMH? If her AMH is more than 3.5 ng, it means that she may have PCOS. This is not a rule, because if other signs and symptoms of PCOD are absent, then you can say only her AMH level is high. Okay. What is normal AMH level? Is between 1.4 to 3.5. Low normal range, that is 0.7 to 1.3, and very low, which is observed around a perimenopausal phase, is that 0.3. Now coming to Ayurvedic concept, how we can now if you ask me, there is nothing which can be directly compared to low AMH or reduced ovarian reserve has been given in Ayurveda text, but we always try to correlate the things. So let's try to correlate and connect the dots between this dosha dusha samurchana and the clinical picture that we get. So as per me, the dosha responsible for low AMH is Vata, or it could be Tridosh, but it will always have a Vata predominance over it. Dusha includes Rasavaha and Artavaha Srotas. Agni, there will be Dhatwagni Mandya, and then only the Rasavaha Srotas will get Dushti. Srotas includes Rasavaha Srotas and Artavaha Srotas. Sroto Dushti Lakshan will include Artav Nash. Now we all know that in Ayurveda, Artava or a Raja or a Bija, these words have been used in multiple ways. Sometimes it means the menstrual blood, sometimes it means the female oocyte, sometimes it means the fertile period. Okay, so here I have taken Artava with respect to the female oocyte or the follicles. Okay, so artavanasha, what do you mean by artavanasha? It can be correlated to the depletion of antral follicles, and we have seen that if antral follicles are depleted, then there will be reduction of AMH, because it is the antral follicles which are secreting the AMH. Marga, as we know, the female reproductive system is situated in pelvic cavity, so it is always Kosthagata. Now coming to probable Samprati. Again, we have to apply our certain logic, what we see in patients, what is given in text, and then we have to form the Samprati of those diseases which are not directly explained in the Ayurvedic text. Now, one common factor that we have seen since the beginning is increased maternal age. We have been seeing that as the maternal age increases, the AMH level decreases and fertility decreases. So, increased maternal age, Vata Prakopak Ahar Vihar Sevan, and mental stress. These three are the key hetu which I feel are most important if we try to formulate the Samprapti. Now, these are like increased maternal age is narrated in modern science also. How we can correlate it from Ayurvedic point of view is that as the age increases, there is we all know that during Balyavastha there is a Kapha-dikya, during Tarunavastha there is a Pitya-dikya, and during Vardhakyavastha there is a Vata-dikya. So increased maternal age itself means there is an excess amount of Vata in woman's body, and that will lead to Vata Prakop. Vata Prakopak Nidan 7 will definitely lead to Vata Prakop. Vata Prakopak Nidan 7 will include excessive coitus, excessive talking, excessive laughing, excessive walking, everything. I need not tell you each and every Vata Prakopak Ahar Vetu. Lack of sleep, day sleeping, all these things will lead to Vata Prakop. Now coming to the third hetu, which I feel is most important in today's scenario, that is mental stress. Now mental stress can be dealt with in two ways. That in Agre Samgraha Charkasacharya has said that Saumanasya Garbhadharananam Shrestha. That means if a couple, or to be more precise, here we will take the lady into consideration, that if there is no mental stress, Saumanasya Garbhadharanam Shrestha. That means if there is a equilibrium of mind, or if the mind is happy, that means that is the most important, or the first and foremost hetu for Garbhadharan. That means some mental absence of mental stress will lead to conception. And if the mental stress is present, then pregnancy cannot be achieved. This is the one thing, that is Saumanasya Garbhadharanam Shrestha. Other thing which we can correlate is in Rasava Sroto Dushti, there is a hetu which is narrated, that is Chintanam cha Ati Chintanam. That means if a patient is thinking, overthinking, or is under depression, or is having anxiety, or anything which is depleting her peace of mind, then it will lead to Rasava Srota Dushti. And we all know that Rasa and Raja are so closely related that Raja has been narrated as the Upadhatu of Rasa Dhatu. So if Rasava Srotas is Dushta, then the Rasa Dhatu will be Dushta. If Rasa Dhatu is Dushta, then coming Upadhatu will also get affected in the form of low AMH. So these three factors, as you can see, increased maternal age will lead to Vata Prakop. Vata Prakopak Nidan Ahar Vihar 7 will lead to Vata Prakop, and this mental stress, Saumanasya Garbhadharananam Shrestha and Chintanacha Ati Chintanat, will cause Rasava Sroto Dushti. Now this Vata Prakop will cause vitiation. Now there are 5 types of Apan Vayu. Exactly which Vayu will get altered, that is vitiation of Apan Vayu, because it is situated in the, because the pathology is taking place into the pelvic cavity, that is in Apan Kshetra. Sthana Samshray will be in ovary. Apan Vayu, now there are n numbers of guna of Vayu, like Ruksha, Sukshma, Chala, so on, and Khara, so on and so forth. But here we need to identify exactly which guna is getting increased. So in my opinion, Apan Vayu, though there is a vitiation of Apan Vayu, especially Ruksha and Khara Guna Vruddhi is occurring, which is calling Artavnash, that is depletion of antral follicles leading to low AMH. So these two hetus, these three hetus collectively are leading to low AMH. This is the from Samprati which I have formulated by taking few excerpts from the modern as well as Ayurvedic science. Coming to the next slide, as I have already said that there is no direct narration of low AMH or ovarian reserve depletion. We the only, what you can say, the only way we have is to correlate the things. So I have correlated Yoni Vapat and Artha Dushti and low AMH and low estrogenic state. And this is the chart of it. Let's understand it. First is Yoni Vapad or Artha Dushti, and second is feature that can be compared to low AMH or low estrogenic state. First is Vata Yoni Vapad. As we all know that causative factor of any just give me a minute.
Yes, ma'am, for sure, ma'am.
Just excuse me for few seconds, Jinsi.
Yes, ma'am.
Yeah, my apologies for the interruption. So I was saying we have to compare or correlate Yoni Vapat Artha Dushti with low AMH and low estrogenic state. Now, why I have taken low estrogenic state, that we have been seeing that low AMH is basically because there is a depletion of antral follicles in the ovary. Now, this follicles itself produce estrogen. So, if there is there is depletion of follicles, definitely there will be low estrogen circulating in woman's body. And in menopause also, like we have seen that AMH, low AMH is very, very low AMH is observed in perimenopausal phase. And we all know that during menopause or in perimenopausal phase, there is a low estrogen. So these two things are closely related, and that's why I have taken not only low AMH but low estrogenic states also. So coming to the first, that is Vata Yoni Vapat. So we all know the causative factor or the for any Yoni Vapat is basically Vat. Okay, so out of the 20 Yoni Vapats explained by the Charkacharya, Vata Yoni Vapat had scanty menses. It has got Kharasparsha, Alpa Artha, and all these things. So scanty menses, again we observe in patients with low AMH very commonly exhibit scanty menses. And also perimenopausal women usually have two presentations. They will either have excessive menses or they will have scanty or irregular menses. And hence I have taken Vata Yoni Vapat ka feature directly compared with scanty menses or painful. Coming to Ati Charana. Now in Ati Charana, one of the hetu of Ati Charana is Ati Maithuni. Okay. So, and the feature that is given in text, that is Bijamna Vidanti. Now, Bijamna Vidanti can be compared that there is no bij or no follicle left in the ovary. So, that can be compared to the low AMH. Next is Shushka Yoni Vapat. Shushka Yoni Vapat is Kharasparshacha Maithuni. That means in Shushka Yoni Vapat, now why there is Kharasparsha? Why there is dryness of vagina? During perimenopausal phase, we must have seen when we study menopause, there is a dryness of vagina is one of the feature of low estrogenic states or menopause. Sorry for interruption. So in Shushka Yoni Vapa, there is a dryness of vagina which can directly be compared to the low estrogenic state, which is usually observed during perimenopausal stage. In Vandhya, about Vandhya, they have said that Nashtartavam Vandhya. Now this Nashtartava can be dealt with in two ways. Nashtartava means absence of menses, or Nashtartava can be compared to no functional follicles in the ovary, that is low AMH. Arthakshaya. Now, what is Arthakshaya? About Arthakshaya, the Acharyas have said that Yatha Uchita Kale Adarshanam. Yatha Uchita Kale Adarshanam means Yatha Uchita Kal means the time on which the menses should occur. That is monthly cycle. Say a patient is having LMP of say 1st of September. Then she should get her next menses on either 1st of October or somewhere around 30th September, depending on the duration interval between her cycle. But this will not happen in Arthakshaya, because the feature of Arthakshaya itself is Yatha Uchita Kale Adarshanam, means ideally menses should have came on that particular day, but it is not occurring. That is Arthakshaya. So that can be compared to the scanty or irregular menses. Now Arthav Dushti. Now we all know there are 8 types of Arthav Dushti, like Vataj Pittaj, but in Arthav Dushti there is one common shlok for all Arthav Dushti, and there they have said that Abija can be directly compared to the inability of a patient to conceive because of depletion of that follicles, that is bija in the ovary. Okay. Now coming to the treatment part, how we should approach a particular case with low AMH. Now we have been seeing that if you have listened to my lecture closely, one common or the one most important factor is increased maternal age. Now, so we cannot stop a patient from aging, but like at least in modern, they don't have anything which will stop a patient's aging. We cannot stop, even we cannot stop a patient from aging, but we can stop the effects of aging. Okay. And what is the golden therapy for stopping the effects of aging? That is Rasayan Chikitsa. Here I have highlighted the word Vayasaha Sthapanaha. That means if a patient or a lady takes Rasayan Dravya, that Vayasaha Sthapana, that means her effects of aging can be arrested at least for some time. Now coming to the Falashruti of Rasayan Chikitsa, Dirgham Ayu Smruti Medham Arogyam Tarunam Vayaha. That means what? If you give Rasayan Chikitsa to a patient with low AMH, then the effects of her aging in the form of like see, AMH will tell you number of functional follicles, that means quantity of follicles they will tell you. But in my opinion, for conception, we require only one follicle. Say a patient is having AFC count of 8 to 10 is considered to be normal and good. Say if patient is having AFC count of say 2 to 3, okay, which is very less. But for, in my opinion, for conception, we need only one follicle. Okay, so if by giving Ayurvedic treatment, if I'm able to preserve the quality of that particular egg, then the pregnancy can be achieved. And that's why, though we cannot stop the aging, we can stop the effects of aging at least to some extent by giving Rasayan Chikitsa. Now coming to next, we often take Vajikarana only useful to the male patients, but it is not so. Vajikarana can be applied to female patients also. See, the first line of the shlok itself is saying Yat Kinchit Manasaha. Means what? Yat Kinchit Manasaha. We have seen mental stress as one of the causative factors. Now, what do you mean by Manasaha? Manasaha means whatever is pleasing to your mind, whatever is giving you pleasure of mind. Okay, so it will include your favorable atmosphere. We can apply. I will give you an example how this principle can be applied to present scenario. Say if a lady is working somewhere, she's a working woman, but her job is very much stressful. Okay, the job is very much stressful, she is not able to concentrate, her colleagues are not good, her boss is not good, then what will happen? It will affect her mind, and if her mind is affected, it will definitely going to affect her fertility. The one ideal example of this is, you must have heard that when lockdown was declared and there was no functional, like many of the patients or many of the persons stopped going to work, to their work daily, and they were working from home. Many of the patients conceived spontaneously. Those who were opting for IVF, those patients also conceived. At least I have 4 to 5 patients who wanted to opt for IVF, but they conceived spontaneously. So this is the importance of soundness of mind or happiness. So whichever thing will give you pleasure, whichever thing will relieve you of anxiety, will relieve you of depression, that will act as a Vajikaran Dravya to you. And this explains the why the patient conceived in the lockdown when they were actually not taking any treatment. Now, these are the few references which I have taken from Rasa and Vajikarana Adhyay. These are like, if you study Rasa and Vajikarana Adhyay, most of the kalpa are cumbersome. That means if you want to make them, it will be difficult to make, or the dravyas will not be available, or it will be too time consuming. So here I have taken certain kalpa where the dravyas are easily available. So here you can see the apatyakar swaras. It will, Atmagupta is nothing but the kapikachu, Maasha is nothing but the udid, kharjur, shatavari. All the dravyas are easily available, and if you want to, if a patient is this type of what you can say cumbersome recipes, you cannot ask patient to make at home and eat. You the ideal scenario for this is you get a patient admitted in your IPD and prepare this and give them to drink. Yes, another Vajikaran Kalpa, Apatya, in the Falashruti of Vajikaran itself, they have given Apatya Santanakara, Yat Sadya Sa Praharshanam. That means whichever Vajikaran Dravyas are excellent for Apatya Santanakara, they will help a patient to produce better quality of egg. And that's why Vajikaran should not only be looked for male patient, but it should, the dravyas or the kalpas should be explored for the female patients also. This is one of another Vrishak sheet here. They have taken Kharjur, Masha, Payasya, Shatavari, Madhuka. Madhuka is very important. Madhuka or Yashti Madhu, it is, as you know, it is there in Jivaniya Mahakasha, it is Bruhaniya, it is Madhur Madhur Shita. So by all means, it will aid a woman's fertility. Now coming to actual treatment protocol, which are the drugs you can use for treatment of a patient who is presenting you with low AMH. So first is Hingu Vachadi Churna. Now Hingu, if you study the properties of Hingu, it is stated as Sri Pushpajanana. So Hingu is stated to be Sri Pushpajanana. Here I have taken the meaning of Sri Pushpajanana as to cause ovulation and as to cause development of follicles in the ovary. Vachadi, why Vacha is important? Because we all know that Vacha is Pramathi Dravya. Pramathi means what? It will Nirasyate Doshana, means जो भी दोषों का संचय हुआ है उसको वो निकाल देता है. That is Hingu, and that's why I have chosen Hingu Vachadi Churna. The Hingu by Sri Pushpajanana property and Vacha by its Pramathi property will break whatever the obstruction, whatever avrodh is there. It will be taken care by Vacha, and Sri Pushpajanana will be done by Hingu. Shatavari Taila, we all know that Shatavari is rich in phytoestrogens. Here we are dealing with low AMH, low estrogenic state. So if you add phytoestrogens from outside, it is definitely going to aid a person's fertility. Now coming to Shatavaryadi Rasa and Basti. It is useful for Yoni Vapat and Vandhya. In the Falashruti of itself, it is given that Shatavariyadi Rasa and Basti is useful for patient who is Vandya or who is suffering from infertility. Yograj Gugur, in the Falashruti of Yograj Gugur, it is given that it is Rajo Dosho Haram, means whatever the abnormalities of menses, abnormalities related to Sri Pushpa will be there, it will be taken care by Yograj Gugur. How to use this? I have taken this in actual case presentation, which will come in consecutive slides. Okay. Next is Mustadi Yapan Basti. Yapan Basti are can be used as an Anuvasan Basti. It is used for in males. It is for Shukrajanan. Here you can take it as Artav Janan, and it is Rajo Vyadhi Hara. Sahacharadi Yapan Basti. The advantage of Yapan Basti is that it can be given at any point of time. Now coming to the actual case, the patient name X, and when she reported me, she was already 35 years of age. So you can see here we have been seeing that as the maternal age increases, the fertility decreases. Here the patient, when she came to me, she was already 35, so her AMH already was declining. She was married since past 15 years. Her menstrual history included bleed. She had scanty menses, that means she bled only for 2 to 3 days, and the interval between her two cycles was 26 days. Her cycles were painless. Now again, painless cycles means that the cycles are anovulatory, because in ovulatory cycle there is a release of prostaglandin, and because of this prostaglandin, patient experiences pain. So painful cycles are always ovulatory, and painless cycles, majority of time they are anovulatory. That means there is no ovulation taking place in painless cycle. Ops history, she was a case of primary infertility, so G0. Coming to her history, she had HL scopy before 9 years. HL scopy is hysterolaparoscopy. It is done to see how is the hysteroscopy. Hystero is uterus and scopy is to see. So we put a hysteroscope from vagina and see how is the uterine cavity, and laparoscope we introduce from the umbilicus and see how is the attachments of the uterus, whether both the tubes are patent or not. All these things are seen in HL scopy. So it was done before 9 years, and it was found that both the tubes were patent and no anatomical abnormality was observed. Whenever we do laparoscopy, at that time we do DNC at last, and that sample is sent for the HPE, that is histopathological examination. And when this was sent, it was observed that the uterus or the endometrium was in proliferative phase. So in short, there was no abnormality in HL scopy. She had, here I have highlighted the most important thing, that the patient was already 35. She had undergone 6 IUIs and she had undergone 4 IVF cycles. Now you can understand one IVF cycle costs around anywhere between, if you go to a good institute, it will cost you somewhere around 1.5 to 2 lakhs. And this patient, who was already poor, she had undergone 4 IVF cycles and all the IVF cycles had failed. Coming to her medical history, she was known, and this was a very difficult case actually. She was already a known case of hypothyroidism since 5 years. She was taking medicine for that. She had history of genital tuberculosis. Now, if there is a genital tuberculosis, there is a very poor prognosis because it affects the endometrium also. So her repeat HPE for genital tuberculosis was negative, and that's why I was a bit relieved. So I can give her Uttara Basti, because in the presence of tuberculosis, we cannot give Uttara Basti because it leads to flaring up of infection. But here, as the infection was old and HPE was normal, I could plan for Uttara Basti. The Prakriti was of little bit Vata Pittatmak. Just give me a minute.
Yes, ma'am.
Actually, I am down with sore throat. That's why I am pausing in between. Okay. Her Mala was Vibandha. She was having constipation, and her Agni was Manda. Now coming to her investigations, how her investigations look, you can see her AMH was low. It was 1.3. FSH was 6.47, LH was 1.63, her prolactin level was 10, the serum estradiol level was 143, and on clinical examination, her uterus was AVAF, that is anteverted anteflex, that means no abnormality with respect to the size and position of uterus was there. Fornices were non-tender. Non-tender implicates that there is no endometriosis, because in cases of endometriosis, the uterus is usually fixed and there is a tenderness in the fornices, but fortunately that was not present in this case. Per speculum examination, her cervix was normal. Okay, so whenever this is how the patient progress with respect to treatment is there. But before going to this chat, I would like to say that whenever patient with infertility approaches us, there are basic 3 investigations that you should do. First is USG, second is HSG, and third is HSA, which is not applicable here. The patient already had done HL-scopy. I'm just telling in general. First, to know USG is to know whether her uterus reproductive organs are of normal size and shape. HSG to know whether her tubes are patent or not, and HSA, that is semen analysis, histological semen analysis of husband, to know whether we often, whenever the infertility is there, whenever we often try to focus all our attention on female partner only, but we should know that the male factor is also normal. Only when male factor is normal, then you go for all other investigation. So these 3 are basic investigations whenever a patient with infertility approaches you. So coming back to this particular case, first follow-up, as we had seen that the patient had no hunger, there was Agni Mandya. So after, before 50, so this is before and after. First column is of before and second column is of after. So patient developed the feeling of hunger. Initially she used to have food just by looking at the standard lunch time, say 2 baj gaye, 8 baj gaye, let's have lunch, let's have dinner, like that. But after treatment, she started feeling of hunger. Daily mala pravritti, she had no daily mala pravritti. She usually used to defecate on alternate day, and that too occasionally on straining. But after treatment, her mala pravritti was improved. Majority of time it was regular and without straining. Next follow-up, coming to the scanty menses which she had, she used to bleed only for 2 days. That means scanty menses was 3+, but after treatment, the scanty menses were taken care of. By the end of 3rd month, her menstrual flow increased from 2 days to 4 days. Now coming to the treatment part which I had given her. Now I have classified them. I have classified them in oral and Panchakarma. So coming to the oral therapy which I gave her, Shatavari Churna 2 gram with 5 ml of Falagruta. Time is Pratah Kala. That means early in the morning, patient has to get up around 5 a.m. or 6 a.m. And whenever she gets up, she has to take 5 ml. She has to liquefy 5 ml of Falagrut, and she has to mix this Shatavari Churna 2 gram in quantity, and she has to lick this. She has to lick this, and after this, she can take warm water or warm milk, whatever is convenient to her. So this was given Shatavari Churna. Why I have chosen this, that will also come in consecutive slides. So Shatavari Churna 2 gram with 5 ml of Falgru. This has to be taken only once, not like once she has taken this, it is not to be repeated in the entire day. Next is Pushpadhanva Rasa 2 BD, and time for this is Apankal. Now Pushpadhanva Rasa, the name itself suggests that it is good for follicular development and in turn for low AMH. Now I have given it in the Apankal. Apankal is, what is Apankal? You ask the patient to take medicines before food. Remember, before food, just before lunch and just before dinner, and immediately after that patient has to take lunch or dinner. Why? Because whenever you take these medicines in this particular fashion, then the drug will reach to desired site, that is pelvic cavity or uterus. Okay. Next is Hingu Vachadi Churna. I have already explained about this in previous slide. This is to be taken 2 gram after food. This is a Vyanakal, after food is a Vyanakal. So I had given Hingu Vachadi Churna after food. Yograj Gugur 2 BD. Again, time for this is Apan Kal with Maharasnadi Kwat as a Anupan. Now there is a reference about this Yograj Gugur and Maharasnadi Kwat in Sharangdar Sanhita Madhyam Khanda, that Yograj Gugur, if taken with Maharasnadi Kwat as a Anupan, then it will lead to Rajo Dosha Hara and Vandhanamcha Garbhadam. Means even the infertile woman will have a baby. So I had given Yograj Gugur in Apankal as a. Now how to tell this patient, how to tell this, like she has to take 2 tablets of Yograj Gugur, and Maharasnadi Kwat has to be diluted with equal amount of warm water. So she has to take 2 spoons of Maharasnadi Kwat and add 2 spoons of warm water to it, and she has to swallow this Yograj Gugur along with this liquid and not with the plain water. This is how I tell patients to take Maharasnadi Kwat along with the Yograj Gugur along with the Maharasnadi Kwat. Arogya Vardhini Vati 2 BD has to be taken after food. This is basically for Mala Sanshodhan. In the Falashruti of Arogya Vardhini Vati itself, it is given that Mala Sanshodhani because it contains Kutki, which has got Bhedan property. Okay, so this is the oral treatment which I formulated for her. Now coming to Panchakarma. Now in first cycle I gave her Vaman. For woman, Abhyantar Snehapan I gave with her Falagruta for 5 days, and after that she was given Vaman and she attained Madhyam Shuddhi. Then in the next cycle I posted her for Yoga Basti. In that I gave Anuvasan with Sahachar Tel for Vata Shaman. We all know that any Yoni Vapat, because it's a Vata Kshetra, Apan Vayu Kshetra, our treatment should be focused at for relieving or alleviating the Vata dosha. So Sahachar Tel 80 ml, and for Asthapan I gave her Yashti Madhu Bharad and Apamarga Bharad. Okay, and that how Asthapan is to be prepared, that is to also we should strictly adhere to the guidelines given by our Acharya, that is Makshikam Lavanam Sneham Kalkam Iti Kwatham. That means first you have to add Makshik, that is Madhu, Lavan, that Lavan we all know, Makshikam Lavanam Sneham. Sneham means whichever the Sneha that you are going to use. In this case, I had used Falagruta as a Sneha. So Makshikam, you add honey, you add Lavan, stir it, you add Sneha, stir it, Makshikam Lavanam Sneham, Kalka. Kalka I had used Trikatu Churna Kalka. So Makshikam Lavanam Sneham, Kalkam Iti Kwatham. That means once you are done with adding all these things, at last you are supposed to add Kwatha of Yashti Madhu and Apamarga Bharad. So usually I take 750 ml of Kwatha, and 50 ml will be taken care by this Makshikam, Lavan and Sneham. Okay, so total Basti, Asthapan Basti will be of 800 ml. So she was given Yoga Basti Kram in this fashion for 8 days. Now one advice I will give you: whenever you post an infertile lady for Yoga Basti, make sure that don't start her Yoga Basti anywhere between the cycle. So if a patient is, say, let's take a standard example, a patient who is bleeding for 4 days. So if she is bleeding for 4 days, on day 4 her menses will be over. On day 5 you will start with her Yoga Basti. Yoga Basti will go on for next 8 days. So 8 plus 5, 13 days. So patient will be free by 13 days. So in standard patient having 28 days cycle, on 14th day her ovulation will take place. So on 14th day patient can be discharged and she can have intercourse. So if at all pregnancy occurs during that first intercourse also, then as your Yoga Basti has ended, you will not interfere with the newly formed pregnancy. But if you are planning Yoga Basti say on day 7th or day 8th cycle, day 8 of the cycle, you will end up interfering between her fertile period also, and if pregnancy occurs, you will end up disturbing that pregnancy. That poor lady is trying to conceive and you are disturbing her pregnancy. just because you are posting her at the wrong day of the cycle. So make sure for especially for infertile lady, Yog Basti should be started as soon as her periods end. Okay. Now next I posted her for Uttar Basti with Palagrut. That is in next cycle. Once her menses had ended, she was given Uttar Basti for 5 days with 5 ml of Falagruta. Now there is a reference of Uttar Basti, like whenever you plan a patient, there is a particular example is given that if you have to color a cloth, what will you do? You will wash that cloth first and then you will try to color it so that the color will be nice. Okay. The same way, whenever you want to post a patient for Uttar Basti, don't directly post for Uttar Basti. Do her Sanshodhan plus first in the form of, it could be Vaman, it could be Virechan, it could be Yoga Basti. Okay. But make sure that you do her Sanshodhan first, then only the Sneha of Uttar Basti will be absorbed very nicely and you will get the desired result. Now coming to the choice of the drugs that I had made, why this particular Pushpadhanva Rasa, why particular Shatavari Churna? So this reference is taken from the Aushadhi Gunadharma Shastra by Gune Shastri. It is a very famous book in Maharashtra with respect to the Aushadhi. So let's look at the contents of the Pushpadhanva Rasa and their probable actions. These are given in the Aushadhi Gunadharma Shastra. I have directly taken from there. So Rasa Sindur is Balya and Yogavahi. Nagabhasma is Balya. Abhrak improves the Dhatu proportion krama. Vanga is Vrishya. Loha Bhasma is Rasayan. Shalmali is Vrishya. Yashti Madhu is comes under Jivaniya Gan, Balya Gan and is Rasayan. So Pushpadhanva Rasa, by virtue of all these properties, aids the follicular maturation and in turn may be useful for improving the AMH level. Now remember, in modern science they say that AMH level never increases, it goes on depleting. Okay, AMH level never increases, it goes on depleting. You underline this sentence. But in this particular case, as the patient conceived immediately, I did not get the chance to do her AMH, but she conceived. That is more important. Like only increase in AMH level is of no use if the patient is not conceiving. So conception is more important than increasing the AMH level. And if conception is occurring, we can say that okay, a child is born with a fixed number of follicles. Agree. The follicles cannot be regenerated. Agreed. But whatever the follicles are there, the quantity cannot be increased. Agreed. But the quality can be definitely improved, or the quality can be definitely retained, and that's where Ayurvedic treatment comes into picture. Even with AMH, few of my patients AMH level has increased, but then it will be wrong to say that this particular drugs lead to increasing AMH level, because I have not carried out a research. There are sporadic cases. Say, I think 4 of my patients are showing increased AMH level after treatment, but 3 or 4 cases, what you can say, on the basis of 3 or 4 patients, we cannot make a concrete statement. If I have to make a concrete statement, then I should carry out at least a research on 50 patients, which is my next agenda. And that's why, as I have not taken a large number of patients, I will not say that Ayurvedic treatment improves the AMH level, but I would definitely say that it improves the quality of the eggs. Now, why I have used the Shatavari that we have seen in the Pratahakal. So this is the reference from Kashyap Samhita, Shatapushpa Shatavari Kalpadhyay. Okay, so this is a very beautiful shlok. Let's look at it. Artavam na pashyati pashyanti vipalam chaya. Means what? Artavam na pashyati means there could be amenorrhea. Artavam na pashyati means there is amenorrhea. Pashyati vipalam chaya means though there is menstruation, there is no ovulation. That means anovulatory cycles. Ati prabhutam means menorrhagia. Atyalpam means scanty menses. Atikrantam means जो गया है, the one which is gone. So menopause. Anagatam means जो अब तक आगतम means to come. Anagatam means जो अब तक नहीं आया. Akarmanya visransi means ये सब in the first line they had said that all these are disorders of menstruation. If you observe in any lady, then you go for such lady Shatapushpa Shatavaryo Syata Tatha Amrutam means what? For such lady Shatapushpa or Shatavari are like a nectar. Okay, now they have said in this particular adhyay only that Shatapushpa and Shatavari, they have same properties, but only the virya is different. Shatapushpa is Ushna in virya and Shatavari is Shita in virya. Okay, so Shatapushpa, I personally use Shatapushpa in a patient who is of Vata or Kapha Prakriti or Vata or Kapha Prakriti, and Shatavari in a patient who is of Pitta Prakriti or who is having Pittanubandha. Okay, so this can be according to Prakriti, you can use either Shatapushpa or Shatavari. So this is how I have planned the treatment for this particular patient, and I am glad to say that she conceived within 3 months, and right now during pregnancy, usually what happens in cases of low AMH, even if the patient conceives through IVF, the pregnancy is not continued till 9 months. Patient may have spontaneous abortion or early abortion within first 3 months. That is the biggest challenge that we face. But in this particular patient, fortunately, nothing of that sort happened. That patient conceived and she delivered a healthy child. Okay, I do have a video of this patient. Let me finish this and I will share a testimonial video of this particular patient.
Sure, ma'am.
Yeah.
नमस्ते, मेरा नाम स्वाति जालिंदर आगोने है। मेरी शादी को 14
Ma'am, are you audible? Am I audible, ma'am?
Yes, yes. I'm just sharing the video. Please give me a minute.
Yes, ma'am.
Video is visible. I have blurred the patient's face for identity purpose.
Yes, ma'am, it is visible, ma'am.
Audible. Is it visible?
Yes, ma'am, it is visible, ma'am.
Yeah.
नमस्ते, मेरा नाम स्वाति जालिंदर आगोने है। मेरी शादी को 14 साल में ट्रीटमेंट करती रही, मुझे बच्चा नहीं था। मैंने 4 टेस्ट ट्यूब में भी 6 IUI किए थे। वो सब ट्रीटमेंट मेरी फेल हो गई। मेरा मेडिकल प्रॉब्लम है, थायराइड था, टीबी की ट्रीटमेंट की थी और AMH लेवल लो थी, 1 था। तो मेरी सब ट्रीटमेंट फेल होने के बाद मैं डॉक्टर वर्षा मैडम के पास आई थी आयुर्वेदिक ट्रीटमेंट के। उन्होंने मुझे पहले महीने में उत्तर बस्ती का ट्रीटमेंट स्टार्ट कर दिया। आफ्टर 3 मंथ्स मुझे प्रेगनेंसी आ गई। प्रेगनेंसी के दौरान मुझे कुछ भी दिक्कत नहीं हुई और मैंने रिस्क, मेरा एज ज्यादा होने के कारण मैंने रिस्क नहीं लेना चाहिए और मैंने सीजर कर दी और मेरी बेटी फिट एंड फाइन है और अभी वो 7 इयर्स ओल्ड है। वो उसका नाम वो भी है। थैंक यू सो मच वर्षा मैडम।
Yeah. Am I audible?
Yes, ma'am, you are audible, ma'am.
Yeah. So I'm done with the presentation and I'm done with sharing video as well. So I'm open to the questions if there are any.
Yes, ma'am. Thank you, ma'am. Thank you, ma'am, for such a wonderful session, ma'am, which was very informative, ma'am. We'll go ahead with the question and answer session, ma'am. May I read it out, ma'am?
Yes, yes.
Ma'am, there is a hand raise, ma'am. Shall we unmute the doctor, ma'am?
Yes, yes, sure.
Yes.
Hello.
Yeah, ma'am.
Good evening, ma'am. Thank you for such a nice session.
Thank you so much.
Ma'am, actually, I want to ask about the case you have discussed here.
Yeah.
General medicines you have started that Phalrut, Vishatavari, Pushpadhanva, Hinguvachadi, Arogyavardhani. This all to be continued throughout the cycle.
Yeah. It has to be continued throughout the cycle.
Okay, for all full 30 days, we should continue these medicines.
Yes, yes.
And means nothing to be stopped during menses.
No, if the patient is not showing you menorrhagia and all, then there is no need to stop. If the patient, because of this like Hingu and Vacha, they are Tikshna Dravya. So if patient is showing features of menorrhagia, then you can cut down on those medicines which are Ushna and Tikshna. But if there is no menorrhagia, you can continue.
Okay, so means if ma'am menorrhagia would be there, then we should stop Hinguvachadi and Arogyavardhani.
Arogyavardhani also need not be stopped. Arogyavardhani is not that Ushna and Tikshna as compared to Hinguvachadi.
Okay, ma'am. And as you told about the Panchakarma to be done in this patient, so this Vaman, Yog Basti and Uttara Basti, it should be given in one cycle, means how the protocol should be there along with the oral medicines.
Oral medicines, as I said, it has to be continued throughout the cycle. Okay. For let's say we are planning for say 3 months of treatment. Okay. So in first cycle, I gave her Vaman. In second cycle, I gave her Uttar Basti. Yoga Basti. And in third cycle, I gave her Uttar Basti. So this is like, we all know that Ayurvedic medicine is a customized medicine. There is no one fixed manner to be followed. You see the prakriti of a patient, you see how the patient is responding to your medicine. Okay, accordingly you can change. So if a patient is not ready for, sometimes the patients are not ready for next Panchakarma immediately next cycle. So you can, after woman, you can have a gap of one cycle, then poster for the next cycle. But I would advise that there should not be any gap between Yoga Basti and Uttar Basti, because prior to Uttar Basti, there has to be one Sanshodhan Panchakarma. Okay.
Okay. So, ma'am, as you have given Uttar Basti in the third cycle, just means we should, from which day we should start this Uttar Basti in third cycle?
Very nice question. So Uttar Basti has to be started immediately after the cessation of menses. So say if a patient bleeds for on an average 3 days, okay. So you can start Uttar Basti, you can examine her per speculum. Okay. If there should not be even a spot of bleeding, because if the patient is still bleeding and if you give Uttar Basti, then there are chances of endometriosis. That means you are making that endometrial tissue to go and get implanted into pelvic cavity. So there should not be any active bleeding. If the patient is bleeding for 3 days, give 4th day as a rest. Okay. And then on 5th day, you start with your Uttar Basti.
Okay. And ma'am, as you told, before Uttar Basti, a Shodhan is needed. So as we have done Yog Basti in the second cycle, so in third cycle, before Uttar Basti, one day any other Basti is needed, or just we can start with Uttar Basti?
This I have customized, like before giving Uttar Basti, I give one Asthapan Basti to the patient.
Okay.
Only one. Yeah.
With which drug?
Whichever drug you can use, Dashmul Quad, you can use Yashti Madhu Quad, you can use Apamarga Quad, you can use Sahachar Quad, as per the Prakruti and Dosha Dushya Sampurshana of the patient.
Okay, ma'am. And ma'am, just one more question.
Yeah.
Ma'am, many times patient come who is having a bad obstetric history, repeated abortions, but when patient comes to us with the UPT positive, so what we can guide so that no further chance of abortion should not be there?
Yeah, in case of BOH, like see, sometimes it could be because of torch. So if torch infection is there, you should try to treat. But if the patient is coming to you with a positive UPT, then you can't do anything. Then you can start with Masanumasik Vati, that is Pratham Mas Vati, Dvitiya Mas Vati, which is narrated in Garbhini Masanumasik Paricharya. Then you can advise her diet. You can advise her to, at least in first 3 months, it's a very crucial time of pregnancy. Like majority of abortions occur in first 3 months only. So if she is a working woman, ask her to take rest. Maximum of bed rest should be taken. All these things you can advise.
Ma'am, and can we maybe advise Darpal Ras or Shatavari news?
About Garbhapal Rasna, madam, I myself is bit, because our acharyas have said, but it contains Naga and Vanga. Okay. Garbhapal Ras contains Naga and Vanga. And in the etiology of abortion itself, they have given late toxicity, as per modern I am saying. Okay. So if I'm not sure, because we don't know how the manufacturing companies are making Garbhapal Ras. We don't go to their warehouses and see whether the Naga is properly purified or not, or the Vanga is properly purified or not. So I restrain myself from giving Garbhapal Ras in first 3 months. I don't give.
Okay, ma'am. And ma'am, anything else to be continued after first 3 months?
Yeah, you can continue. See, Shatavari Churna can be given throughout pregnancy. I always stick to the herbal medicines, okay, rather than going for treatment of infertility. I do use bhasma and all, but once the patient conceives, I don't use bhasma. This is how I have formulated my treatment. I give Shatavari Churna throughout pregnancy. I give Masanumasik Vati throughout pregnancy.
Okay, ma'am, in what dose this Shatavari Churna should be given to the ANC patient?
Shatavari Churna, you are asking?
Yes, ma'am.
You can start from 1 gram. If patient is usually with Shatavari Churna, certain patient complain of nausea and vomiting. If she is tolerating 1 gram well, then you can go to 2 gram, and if she is not tolerating, then you can continue with 1 gram only. 1 gram.
Okay, ma'am. Okay, ma'am. Thank you, ma'am.
Yeah.
Thank you, ma'am, and thank you, doctor. Moving on to the next question. What can we predict from AFC and ovarian volume, ma'am?
Yeah, AFC is anterior follicle count. Antral follicle count. So this is a job of radiologists. Basically, they divide ovary in a perpendicular manner, and they count how many follicles are there in that particular area. Usually, a count of 7 to 9 is considered to be good. Antral follicle count of 7 to 9 is considered to be good. So if AFC is 7 to 9, it is considered to be good. If it is something 1 or 2, 2 or 3, you can say that there is a very poor ovarian reserve left.
Thank you, ma'am. There is a hand raised, ma'am. Shall we unmute, ma'am?
Yes, sure.
Yes, ma'am. Dr. Kritika, you can unmute yourself.
Hello, good evening, ma'am.
Yeah, good evening, Kritika.
Thank you so much for your valuable information.
Yeah.
One query is, I have 2 queries. First is that we need to generate awareness regarding the late marriages which are happening due to some IT or somewhat related to the scenario present, and moreover it is affecting the biological clock of our body.
Yes.
So preventive health care, which is the handiest point from your side, so that we could go in the community health and generate that awareness in our adolescent health. Number 2 is that thyroid, most of metabolic disorders occurring, and Srota Vrudata is there. So all these points, does thyroid also affect low AMH? Is there any relevance to it or not?
Yeah, so coming to your first point about community awareness about what you can say implications of or repercussions of late marriage. So we can do only one thing, ma'am, that we can tell people that if you get married late and if you prolong pregnancy even after marriage, then there are chances that one, you may not get pregnant. Second, even if you get pregnant, there is a probability of getting abnormal child. That is the only thing we can do from our side. We cannot compel patients to get married just to produce babies. Okay.
Right.
So
I'm talking about medical terms only, ma'am.
So we can only tell them that, yeah, this is the scenario. Like if you, your biological clock is ticking, and if you delayed beyond a point, then these are the repercussions that may happen. And the decision is theirs. If they want to get married for child, they will get. If they don't want to get, because as they say that you don't get married only to produce children, right? You need a right life partner. So
Ji.
getting married only to produce children will not be a right thing to tell them.
Definitely.
Yeah. So this was your first point. Second point, I'm sorry, I forgot, what was your second point?
Thyroid, ma'am, is the hypothyroidism decreasing the AMH levels? Is there any relevant study done on that?
There is no what you can say relevant study connecting the hypothyroidism and low AMH. There is no, at least in modern.
Because ovaries are duly affected because of hypothyroidism in most of the cases we have seen. Obviously, it is a hypothalamus axis, no doubt, but thyroid has been seen in so many cases with that impact, with PCOS, and further leading to infertility. I was not aware whether AMH is also affected or not.
That's what I'm saying, that there is no concrete study to claim that thyroid disorders affect the AMH levels.
Okay, ma'am.
Yeah.
Okay. Thank you.
Yeah.
Thank you, ma'am, and thank you, doctor. Moving on to the next question. Annuulatory cycle and AMH, is there any link in these two, ma'am?
Okay. Now, let's look at anovulatory cycles. What are anovulatory cycles? Cycles in which there is no ovulation. And low AMH is something that your antral follicle count is low, or the follicles are not secreting the AMH particular substance. So there is no directly, like patients who is not with normal AMH may have anovulatory cycles. Like there is a classic example. I'll give you an example of PCOD. In case of PCOD, the AMH level is too high. Sometimes it is 7, 8. So this is something which we don't want. Okay, AMH level is too high in PCOD, but in PCOD there are anovulatory cycles. That means even if the patient gets menses, the cycles are anovulatory.
Okay, ma'am. Thank you, ma'am. Moving on to the next question. As you explained that FSH should be measured during the second or third day of menstrual cycle. If the woman has 2 to 3 months amenorrhea, how to measure the LH and FSH value, ma'am? Can it be measured at any time, or is there any specific day for amenorrhea patient also, ma'am?
Very nice question. A patient having amenorrhea, okay, I will answer this query in two ways. Say a patient is married and patient is unmarried, patient A and patient B. A patient who is unmarried and presenting to you with amenorrhea. Now always remember, we always think of pregnancy only when the patient is married, but it's a routine practice in gynec. Any patients of reproductive age group, irrespective of her marriage, if she is presenting you with amenorrhea, first rule out the pregnancy. So even if the patient is unmarried, presenting you with 2 to 3 months of amenorrhea, get her UPT done, rule out pregnancy. If the UPT is negative, you can give her withdrawal medicines, like you can give a tablet Divari 10 mg for 5 days. After stopping the tablet, within next 7 days, the patient will get her cycles. And on day 2 or day 3, you can measure her FSH or LH. This is for the patient who is trying to, who is unmarried. And for married patient, you do her UPT. If you find out that she is pregnant, then no need to do her FSH or LH, क्योंकि जिस चीज के लिए हम लोग FSH LH कर रहे हैं वही अच्छी हो गई pregnancy. And if there is say UPT is negative, then follow the same pattern which we have followed for the unmarried patient.
Thank you, ma'am. Thank you so much, ma'am. Moving on to the next question, ma'am. What preparation to prepare out of Kapikachu, Marsha, ma'am? Quantity of each drug, ma'am.
So I had given the reference of Apatyakar Swaras for the detailed kalpa, or for the detailed recipe of it. You can refer to Rasa and Vajikarana Adhyan of Charak Sanhita. The detail of it is given.
Okay, ma'am. Thank you, ma'am. Moving on to the next question, ma'am. Hinguvachadi, good quantity of drug, ma'am.
Hinguvachadi vati, it depends on which pharmacy is preparing it. The one which I used was of 500 mg.
Okay, ma'am. Thank you, ma'am. Moving on to the next question, ma'am. Next question is,
Yes.
Shadavariyadi Rasayana Basti ingredients and method of preparation, ma'am.
Can you please repeat?
Shadavariyadi Basti, ma'am.
Shatavariyadi Basti. These
Rasayana Basti ingredients and method of preparation, ma'am.
Whoever have asked this question, there are a detailed description of how to make these bastis, be it Mustadi Yapan Basti, be it Shatavariyadi Rasayan Basti. These references are there, and like one basti is having around 15 to 20 dravya, which I am not able to reproduce over here. So if you want, I can share the references later.
Okay, ma'am. Sure, ma'am. Thank you, ma'am. Moving on to the next question, ma'am. How Mustadi Yapana act as Rejo Vyadihara, ma'am?
Yeah, it is given in the Falashruti of Mustadi Yapan Basti only. And if you see like contents of any Yapan Basti, they are usually Madhura Shita Dravya, which will like, if we say what, it is a Vyadhi which is occurring in the area of Apan Vayu. It is a Vyadhi which is occurring because of the increased maternal age. So all and all Vata dosh is in predominance. So if you are using any dravya which is Madhura Shita, so you are doing the Nidan Parivarjan. So ultimately the disease will be taken care of. And that's how the Yapan Basti, any Yapan Basti will lead to Rajo Doshahara.
Thank you, ma'am. There is a hand raised, ma'am. May I unmute Dr. Damma?
Yes.
Yes. Dr. Vineet, you can unmute yourself. Dr. Vineet? Dr. Vineet, you can unmute yourself. Ma'am, I think he's not there, ma'am. Shall we move on to the next question, ma'am?
Yeah, sure.
Yes, ma'am. Ma'am, even if the lady conceives after the treatment, whether the risk of pregnancy will be reduced? I mean, after 30 years, the pregnancy is considered as high risk, right, ma'am?
Yeah. Does it mean that the abnormal probability of abnormal baby after 30, right? That's
yes,
what
ma'am.
the viewer is trying to ask. Yes. So yes, we all know as the maternal age increases, the quality as well as quantity of woman's egg decreases. So even if the patient conceives, yes, there is a possibility of having abnormal child, but I say possibility, it's not the rule, because I have seen patients conceiving in their 40s and having absolutely normal child. So to rule out this, to relieve ourselves of this threat, what we can do, you can perform NIPT, that is non-invasive prenatal testing. It includes the double marker, triple marker, and quadruple marker test. These are called as a screening test. Okay, so if the patient is falling, is known to be like, this test will not tell you that the baby is suffering from particular abnormality or not. They will give you only an estimate. Like say, if I take 100 patients of same maternal age, same biological age, same gestational age, then out of 115 patients may have Down syndrome. This is the probability that is given by this double marker, triple marker, and quadruple marker test. So if the patient is falling in danger zone through double marker or triple marker, then you can pose that patient for the screening test. Screening test is the not screening test, diagnostic test, that is chorionic villus sampling and amniocentesis. So in chorionic villus sampling, we take the a tissue of placenta and we do its karyotyping to know whether the baby is actually suffering or not. Same with amniocentesis, but in amniocentesis, instead of the placental tissue, we take the amniotic fluid and we do its karyotyping, and this diagnostic test will give you confirmed diagnosis whether the baby is suffering for particular abnormality, be it Down syndrome, be it Patau's syndrome, be it Edwards syndrome, be it trisomy 21, be it trisomy 18. This test will tell you the definitive diagnosis. So if the patient conceives who is in high risk age group, say 35 plus, then go for NIPT.
Thank you, ma'am. Moving on to the next question, ma'am. What is the drug used for Vamana, ma'am?
Drug used for the woman, you are asking?
Yes, ma'am.
Induce woman?
Yes, ma'am.
Madhu Kashay. Yashti Madhu Kashay.
Okay, ma'am. Thank you, ma'am. Moving on to the next question, ma'am. Please repeat the time of Yoga Basti in the cycle, ma'am.
Yeah, Yoga Basti, if you are doing Yoga Basti of unmarried patient, okay, who is not trying to conceive, say a 20-year girl is coming to you for treatment of PCOD, okay, in that patient you can start Yoga Basti from any time of a cycle. But for patient who is trying to conceive, always start Yoga Basti immediately after her menses end. Don't cycle end Yoga Basti whenever the patient comes to you. Say patient is coming to you on day, say 18th of her cycle. Okay, she's coming to you on day 18th of a cycle, and if you start her Yoga Basti on day 18th, you don't know whether if the patient had coitus on say day 14 and she is conceived and it's a early pregnancy, then you will interfere with her early pregnancy, because as the pregnancy is early, even the patient is unaware that she is pregnant. So for patients who are trying to conceive, always start Yoga Basti immediately after her menses ends. Why after menses ends? Because as she had menses, it is a clear-cut indication that the patient is not pregnant. Okay, so there is no chance of interfering with her pregnancy. So if, say, we'll take a standard example, if the patient is bleeding for 3 days, give a 4th day as a gap, and for day 5 you can start her Yoga Basti.
Okay, ma'am. Thank you, ma'am. Moving on to the next question, ma'am. Should Shadapushpa be given in the early phase and Shadavari after 15 days of a cycle, ma'am?
But the Pushpa in early phase, it depends on dosha dushya samurjana and prakriti of the patient. Like I said, I usually use Shatavari for patients who is having Pittanubandha or who are of Pitta Prakriti, and Shatapushpa in patients who is having Vatanubandha, Kaphanubandha, or of Vata or Kapha Prakriti. Because Shatapushpa is of Ushnavirya, you can try whichever permutation and combinations that are useful to you as per the patient.
Thank you, ma'am. Moving on to the next question, ma'am. The question is, can we have plain ghee to have healthy ovulation, ma'am?
Plain ghee, like it has to, if you want, see, there is no actual study conducted that consumption of ghee led to ovulation. But okay, if like I will go by the what Ayurveda has narrated, that a stree who consumes ghee and kheer on daily basis in her rutukal lasts for her entire cycle. So in that way, yes, you can. But again, this finding or this thing should be documented by doing the follicular study of the patient. So I cannot say, like, I have not done this research and I have not seen, but theoretically it can be said.
Thank you, ma'am. Moving on to the next question, ma'am. It is a case, ma'am. In 37 years old primary infertility female with 1 blocked fallopian tube and 0.4 AMH, history of hypothyroidism, she is a Kafaja Prakriti with oligomenorrhea, treated by various Ayurvedic doctor but no results. Kindly guide in this, ma'am.
See, 1 fallopian tube is blocked. Okay. This was the diagnosis, this fallopian tube block, diagnosis on HSG or HL scopy.
Not sure, ma'am. It is not mentioned, ma'am.
Okay. Because see, sometimes HSG gives false negative result, that even if there is no blockage, the HSG may show blockage because of the spasm. Okay. Because during HSG, the patient is not completely anesthetized. We give only local anesthesia. Okay. So if it is a HL scopy finding, it is more authentic. Okay. So we'll consider that it is of HL scopy. Then coming to her AMH level, which is 0.4. We have already seen the clinical levels of AMH. Already the patient is 37 old, and 0.4 is like extremely low fertility. Like in this patient, what I feel, like this patient should opt for IVF because very less time is left in her hand. And we don't know, like we have not formed, not I and not any of the Ayurvedic Vaidya has formed, like, oh, it is 0.004 from Deepali Kakade. Is that, are you the one who is asking this question? I just saw the chat box. Is it
Yes,
0.4
ma'am.
or 0.004?
It is 0.004, ma'am. Deepali.
No, that 0.004 is extremely functionally there is no follicle left in the ovary. So had this patient approach me, say, I don't know what Dr. Deepali will do, but if such patients comes to me, okay.
Excuse me, ma'am.
Yeah.
Ma'am, I think this case is different, ma'am. That is different, ma'am. That was 0.4 only, ma'am.
Okay, that was 0.4. Okay.
Yes, ma'am.
So how I would approach this particular case is 0.4 AMH is like very low fertility, very few follicles are left. If this patient is coming to me with previously tried and tested IVF, that means she had done IVF, no result, and she is coming to me, then I will do her treatment. But if the patient is very much affording, she has not done IVF, then I will first refer her for IVF, because at 37 years of age and only 0.4 of AMH, she has left with very little time for her. If IVF offers at least 30% of success rate, we Ayurveda physicians have not carried out any such result that this particular definitive treatment and the patient success rate is of 30%. So in my opinion, if there are hopes in allopathy, then the patient should try IVF first. If that fails, then she should try Ayurvedic medicine.
Okay, ma'am. Thank you, ma'am. Moving on to the next question, ma'am. The question is, what is the Anupana for Shatavari Churna, ma'am?
The Shatavari Churna, which this particular patient I gave along with Falagrut, I gave if you refer to the Adhyay, Shatapushpa Shatavari Adhyay, they had said that after this particular Shatavari you have taken, you have to eat rice with milk. This is the actual reference from Shatapushpa Shatavari Kalpadhyay. But like sometimes patients don't take, like if the patient is waking up at say 5 a.m. or 6 a.m. to consume Shatavari, then it is difficult for them to eat rice and milk early in the morning. So what I tell, you either take it as a warm, with warm water as a anupan, or you take warm milk as a anupan.
Thank you, ma'am. Moving on to the next question, ma'am.
Yes.
The question is, are Manogunas significant and clinically helpful in increasing AMH values? If so, kindly advise which particular Medhya Dravya has impact on it, ma'am.
See, I will not say that Manas Guna or particular drug, Medhya drug will increase AMH, because see, to say something, there has to be research carried out. And I have not come across any such research, at least in Ayurveda, where they have used Medhya Rasayan to increase the AMH level. But yes, the like happiness of mind, as I had said, Saumanasya Garbhadharananam Shrestha, I don't know whether it will increase. Again, I am saying AMH value does not increase. This is the bottom line. Few of my patients AMH value has increased. This is also I am saying. But on sporadic cases, we cannot make a concrete statement. For me to make a concrete statement that this particular drug or this particular Manas Dravya increases AMH value, I should have with me at least a research of 50 patients. Then I can say. Like whenever, see, we say PCM relieves fever. So they have carried out research on say hundreds and thousands of patients, and then they are saying that. So sporadic cases, even I cannot make a concrete statement. But yes, Saumanasya Garbhadharananam Shrestha, it is there. It may not be indicated in the increased AMH level, but pregnancy can be achieved. This is what I am saying. So
Thank
what
you.
I'm saying, even at the conclusion of lecture also, I said ki I don't know whether it will increase AMH value or not, but AMH value is nothing but a quantity of eggs. But what I am saying, that whichever small number of follicles are left, we can improve its quality.
Okay, ma'am. Thank you, ma'am. Our session is live streamed in YouTube, ma'am. There are few questions there, ma'am. May I read it out, ma'am?
Yeah, how many questions are there still left?
There's just only one more question, ma'am.
Yeah, then it's okay.
Yes, ma'am. Ma'am, the question is Siddha Magaradhwaja is useful in AMH, ma'am? Low AMH level, ma'am.
What Siddha?
Magaradhwaj is useful in low AMH, ma'am.
Useful in low AMH. I have not used Siddha Magaradhwaj in patients with low AMH. So I will not, I'm not able to comment on it because I have personally not used it.
Okay, ma'am. Thank you, ma'am. That's all for the questions, ma'am. Shall we wind up the session, ma'am?
Yeah, sure.
Yes, ma'am. Thank you so much.
At the conclusion, I would like to thank DIKSHA Academy for inviting me as a guest speaker. And most important, special thanks to my intern, Rushikesh Gauri, who has helped me in forming the PPT because I was too occupied since past 1 week to form the PPT. But I just gave him material and he has formulated the PPT. So I'm thankful to him. And the Department of Sri Roga and Prasiti Tantra of D.Y. Patil School of Ayurveda, Nehru, and the D.Y. Patil University itself. It's a big name.
Thank you, ma'am. Thank you, ma'am. That was really a wonderful session, and thank you for answering all the questions with patience, ma'am. Thank you all for the patient listening and valuable time spent. I'm summing up the session with John F. Kennedy's verse. Efforts and courage are not enough without purpose and direction. To know more about our updates, please do stay connected with our social media platforms. That's all for today's most interesting session with lots of new information. Thank you all for joining us. Thank you. Good night. Good night, ma'am.
Jinsi?
Yes, ma'am.
Please don't end the session. I'm just taking the screenshots of the questions asked.
Okay, ma'am.
Just give me a minute because I
Yes,
can
ma'am.
read the questions. I was
Yes, ma'am.
answering them.
Yes, ma'am, for sure.
Yeah, thank you so much. Also, a kind request to you, Jinsi.
Yes, ma'am.
Can you please, I will share my email ID. Can you please mail me all the chat box things?
Yes, ma'am, for sure, ma'am. We'll do it, ma'am. Ma'am, we'll do it, ma'am.
Yeah, thank you so much.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.